Good afternoon, and welcome to the American Brain Coalition's 2023 Educational Series webinar on the Inflation Reduction Act, or you'll hear it referred to as the IRA during today's presentation. My name is Leslie Ritter. I am the chair of ABC's Advisory Committee, or Advocacy Committee, sorry. And I'm also the Associate Vice President of Federal Government Relations at the National MS Society. So, as before, this educational webinar is designed to help ABC's members understand what was included in the Inflation Reduction Act, where the implementation stands right now, and key policy changes that will impact the brain health community. So the IRA included a bunch of different proposals. Those were tax, energy, climate, and healthcare policies. It passed Congress and was signed into law a little more than a year ago. So now the relevant agencies are working on implementation of the law through those different agencies through the regulatory process. And if you joined us for our previous webinar on Regulatory 101, you know that the regulatory process is an important part of the implementation process in seeking stakeholder input and setting out the parameters of any new law, including the IRA. So we want to highlight the portion of the IRA that we'll be discussing today is the part that has the direct impact on the brain health community. So those are healthcare provisions that were included in the law. Today's webinar will focus only on those health-related provisions, namely changes in Medicare that impact prescription drug affordability, including an out-of-pocket cap and the Medicare prescription payment plan, as well as Medicare negotiation. I know that many members of the brain health community advocated for various parts of these of the law and of these healthcare provisions. So we will be going a little deeper into what was included in the law and where things stand right now. We also understand that we have a very diverse membership here, and that's kind of the beauty of the ABC. But in keeping with our educational focus of today's webinar, we ask that you table any questions related to advocacy initiatives or legislative initiatives related to the IRA, but welcome those nonprofit members who want to bring these questions to the advocacy committee. Please do so. We're happy to engage in those conversations, but the focus of this webinar today is just purely educational. So if you need information on how to attend the advocacy committee meetings or need more information on the advocacy committee, please don't hesitate to reach out to Katie or myself, and we can get you connected and get you attending those meetings. Shameless plug for the advocacy committee. I'd like now to introduce Erica Miller, who is a partner at CRD Associates. She has nearly 2 decades of experience in health policy and advocacy. CRD Associates, as many of you know, has been the ABC's legislative consulting firm since ABC was incorporated back in 2004. So Erica will walk us through the IRA, drawing on her expertise in navigating both the federal legislative and the federal regulatory process. So at the end of today's presentation, we'll have time to get to some of your hot questions. So please do put those in the Q&A box down at the bottom of the screen. And we'll get to those at the end of the presentation today. So thank you so much for attending. We're so grateful that you're here. And Erica, I will turn it over to you.
Thanks so much, Leslie. It's great to be here with everybody today. Looking forward to talking to you about what is included in the Inflation Reduction Act. This is really just meant to be a 101, as Leslie shared, what's in the law, where we are with implementation, and what it means for ABC and its members at this point in time, knowing that a lot could change moving forward. But as Leslie said, this bill was signed into law just a little over a year ago. I do think it's important to highlight today that this was passed by Congress on a party line basis using the reconciliation process. So in the last Congress, when Democrats controlled the House, the Senate, and the presidency, they were able to get this legislation through without any Republican support. And as Leslie mentioned, it was quite comprehensive, but we are just focusing on some of the healthcare policies as they relate to Medicare. The Medicare drug price negotiation gets a lot of headlines as it relates to the Inflation Reduction Act, but there were other pieces in the healthcare package that impact patients and providers and manufacturers. And so we'll talk about those today. As I kind of already said, the drug pricing reform provisions get a lot of the highlights as it relates to, and headlines as it relates to this law. And they were the first changes to the Medicare Part D since it was implemented in 2003, which is probably why it gets so much attention. We're going to focus on just 3 pieces of the drug pricing reforms: Part D benefit redesign, the inflation-based rebates in Medicare Parts B and D, and the drug price negotiation in Parts B and D. I will say that there are additional provisions that you probably have heard about. There was a cap on cost sharing for insulin, obviously not related to brain health, expanding eligibility for the Medicare Part D low-income subsidy program beginning next year. And then it delayed the implementation of the drug rebate rule, which was really a way to try and save some money. But I won't get into those things, just the 3 pieces that are on this slide. So starting with Part D benefit redesign, and maybe the thing that gets the biggest headlines is that Part D, the out-of-pocket costs for enrollees in the program will be capped at $2,000 and then indexed for inflation going forward. And we are seeing these changes be implemented kind of over a 2-year period. And you'll see more of that on the next slide. Next year, there's going to be a cap at $3,250. And then also the beneficiaries' co-insurance requirement for when they're in the catastrophic threshold will be capped at 5%. I will say that right now there's no out-of-pocket limit, but there is catastrophic coverage for high out-of-pocket costs. In 2022, that threshold was set at $7,050. So that is obviously a lot of responsibility financially for beneficiaries compared to a $2,000 cap. I'm also going to talk about how patients can spread that out-of-pocket cost of $2,000 over a year rather than potentially paying it all at once if they have to get a high-cost drug. And I will just note that there are different requirements about how discounts on brand name drugs and generic drugs are going to be applied going forward. I will also just note too, we'll talk a little bit about premiums. That Part D premium increases are going to be capped to no more than 6% from the prior year from 2024 to 2030. But after 2030, there's no limit on those premium increases. So I just will thank the Kaiser Family Foundation for letting me steal this graphic here. And again, I think this shows kind of where we are under current law and where we're ultimately going in 2025. Again, we have the out-of-pocket spending threshold before patients go into the catastrophic coverage piece that does have that additional enrollee responsibility. And you'll see in that catastrophic coverage threshold above there that Medicare does pay a significant amount of money for beneficiaries who fall into that kind of level of coverage. You'll see, again, I mentioned that the out-of-pocket spending threshold will be $3,250 next year. You'll still see that large Medicare responsibility in the catastrophic coverage area. But moving over to 2025, I think we've already talked about the $2,000 out-of-pocket cap that, again, will be indexed for inflation. But it's important to look at what happens in that catastrophic coverage area. You'll see that the Medicare responsibility goes down a lot. The drug manufacturer responsibility in that category increases, and so does Part D plans. But ultimately, this is putting less pressure on patients and the Medicare program. And I think it's just important to note when we think about where Congress was when they were developing this whole package as it relates to Medicare prescription drugs, whether it be negotiation or this cap on out-of-pocket costs, they were really looking at Medicare spending on prescription drugs and trying to figure out how to control those costs. Whether they succeeded, it's still too early for us to tell, but that was where they were trying to go. But I do want to highlight that for patients, the Kaiser Family Foundation did estimate that there were $1.4 million $1.4 million enrollees who incurred out-of-pocket costs above $2,000 in 2020. And there were 1.3 million of that 1.4 who had spending above the catastrophic coverage threshold. So you can see how there could be significant savings once this cap goes into effect for well over 1 million Medicare beneficiaries. I will also say that this could be beneficial for beneficiaries with high price drugs, thinking about patients who might have MS or cancer and require, expensive Part D drugs. You could see how this out-of-pocket cap could greatly benefit them. But again, what could be some of the downsides of this, which we just don't know yet? Could the premiums increase after, significantly after that 6% cap is lifted? Could there be more prior authorization? A move to try and only cover more generics? These are things that we don't know. So in exchange for kind of that lower out-of-pocket spending cap, there could be some unintended consequences that we're just, can't anticipate yet. So moving on to the Medicare prescription payment plan timeline. Some of you might know this as the smoothing program, but Medicare gave it this really catchy name that's tongue-in-cheek, the Medicare prescription payment plan timeline. I actually did a call with some of the staff at CMS who are working on this, and they even kind of joked about the name, but that's neither here nor there. I will just say on this slide that you can see a timeline of what CMS is doing between now and implementation of this program on January 1st, 2025. I will note that a guidance came out already on this program, and it's supposed to be the first of 2 guidances. And then, we will have these finalized next year, both guidances going into 2025. The guidance that did come out, the comment period closed late last month. So all of you know, I went to law school because I don't like math. And there was a lot of math in this guidance document, which was basically trying to figure out how, which beneficiaries this would best apply to based on their spending. Ultimately, beneficiaries would have to opt into the program. And I will just note again, we've got a $2,000 out-of-pocket cap. So if you are a beneficiary who perhaps has is on really high cost drugs that are prescribed early in the year that maybe have a coinsurance of $2,000 or more, or $1,500, you could then opt to spread that out in a payment plan over the course of the year. But if you had, spending, out-of-pocket cost spending that was sort of low in the beginning of the year, and then were diagnosed with a condition and prescribed a new drug that was high cost, in the last quarter of the year, this would be less beneficial because you would have to cover those costs in the last 3 months of the year. What I think is important to note is that the second guidance is going to be more instructive for patients and potentially providers. Patients are going to have to figure out, one, if they want to opt in. They're going to have to, CMS is going to have to figure out the best way to conduct outreach on this provision. Is it through providers? Is it through pharmaceutical companies? Is it when patients enroll in their Part D plans, and perhaps if they were had the same Part D plan last year, the plan could give them some guidance on whether they would benefit based on their previous year's spending. But ultimately, I think there's a lot that needs to be determined about how this is going to be rolled out. It will benefit some beneficiaries, but not all, particularly those who know that they have high costs earlier in the year that then can be spread out. But this is another kind of piece that goes along with that $2,000 out-of-pocket cap. I also just want to highlight that what the IRA tried to do was try and put Parts D and B on the same footing when it came to cost sharing for vaccines. Basically, prior to the implementation of the IRA, and this went into effect already, if you got a Medicare beneficiary got a vaccine under Part B, and it was recommended by the CDC Advisory Council on Immunization Practices, there wouldn't have been cost sharing. But if you got a vaccine under Part D, that wouldn't have been the case. So now, if you have an ACIP recommended vaccine under Part D or in the state Medicaid programs, beneficiaries are no longer paying coinsurance. So this is really just trying to equalize the programs and make vaccines the same in the different parts. So I do also want to focus a bit on rebate reform. This is a big provision that has also gone into effect already. I will note that prior to rebate reform in Parts D and B for Medicare, there was no authority to limit annual price increases on drugs in these two different parts of the Medicare program. Medicaid has had a rebate mechanism in place. So this isn't new on the Medicaid side, that is still in existence, but this basically is putting a program in place for Medicare. And so if the price of drugs is in these two parts, B and D, increases faster than inflation, if it's a single source drug or biologic, then ultimately a rebate will have to be paid back to CMS. I will just note that there is an HHS Office of the Inspector General report that showed that average sales price increases exceeded inflation for 50 of 64 studied Part B drugs. This dates back to 2015. But this is an issue that, has been going on for some time and was an opportunity for Congress to try and address it through legislation. So I will note that the implementation started last fall for Part D, started this year for Part B. And so what does this ultimately mean for coinsurance? Again, coinsurance for patients is 20% generally, but obviously if the cost overall is lower for a drug, that 20% is going to go down. So what CMS has estimated is that as of April 1st, people in traditional Medicare would be paying lower coinsurance for certain Part B drugs, and they had estimated that patients, Medicare beneficiaries, were saving between $1 and $149 per dose. And then ultimately CMS is going to invoice the manufacturers for these rebates in 2025. I will note, as of last week, October 1st, we had the next kind of tranche of Part B drugs that were subject to these rebates. There were 34 Part B drugs in a press release that CMS put out. They said that patients will be paying an average of $618 less per dose. But again, the benefit to patients is going to depend on what drugs they're prescribed, if they fall onto this rebatable drug list, and what they were paying out of pocket. If they had a Medigap that was covering the cost, they might not see savings accrue. And again, this is going to vary from quarter to quarter, since the prices for these drugs are updated on a quarterly basis, and that's when the determination about whether a rebate needs to be paid back to CMS is going to be made. For Part B drugs, where providers are the ones buying the drugs and then administering them, Medicare will ultimately pay healthcare providers the difference, so they will be made whole. Thinking about what does this mean ultimately for patients, we might see a limit on out-of-pocket drug spending growth. But the question is, what's going to happen to premiums? Will premiums ultimately go up because of this? I think we just don't know. Could they go down because of this? Potentially. We just don't know. But I think that there is criticism that ultimately with this provision, that manufacturers will just set their market entry prices higher, which again could put upward pressure on premiums. But again, we are not that far into the implementation of this provision, and so again, we just don't know what the impact is going to be. But patients again might be seeing a benefit on their kind of lower out-of-pocket coinsurance costs, based on whether the drugs that they take are on this list. And I think kind of what's going to happen with premiums going forward has yet to be seen. So I will spend time talking about kind of the part of this law that gets all the headlines, the negotiation piece on Medicare Parts D and Part B drug prices. This is something that CMS is actually just kind of getting started in their implementation of. We're in the first kind of cycle of this program, but I will just say that since The Medicare Modernization Act authorized the Part D program. This is the first time that CMS can negotiate directly with manufacturers. Ultimately, the original legislation, the 2003 legislation, included a non-interference clause, which prevented the secretary from negotiating prices directly. I will say that ultimately the prescription drug plans put in bids to participate in the Part D program, and then were able to contract with Medicare and then compete with the other Part D programs for enrollees. The plans then negotiated directly with drug companies, even though Medicare could not do that itself. And so this was, to allow competition in the market. The last Congress that passed this bill did not feel that that competition was controlling drug prices. And so the IRA amended that non-interference clause and allowed for direct negotiation between CMS and manufacturers. So CMS has, since the beginning of the year, has been rolling out how they are going to implement this program, and they ultimately are using guidance. And I think that this is a really important thing to highlight. It was specifically directed in the statute that they could use the guidance process rather than notice and comment rulemaking. But because notice and comment rulemaking doesn't have kind of the same force as a guidance, doesn't have the same weight as a notice and comment rule, I will say that this is something that is opening the administration up to litigation, which we'll talk about later. I will say that CMS has said, since it's been releasing its first guidances early in the year, as it continues to release guidance and try and engage the public on this, they really do want to hear from stakeholders, and they're trying to provide opportunities for that. How those public engagement processes are working, again, I think it's too early for us to tell what the impact will be, but there are opportunities, and we'll talk more about that. The initial negotiation that is going on now will be for price implementation in 2026. I will just show you this slide here. I have the 3 years on this timeline here for the prices to take effect, the negotiated prices to take effect in 2026, 2027, and 2028. I did this because 2028 is the first year that Part B drugs will be included, and because the agency had limited time between passage of the law last August and then implementation for 2026, you'll see that the kind of timeline is a little bit truncated for the negotiation that is going on right now. September 1st was the deadline for CMS to release the list of drugs that were being negotiated, which we'll talk about. October 1st, which just happened last week, that was the date where manufacturers whose drugs were on that list had to indicate whether they were going to participate. Those manufacturers did indicate that they would participate. And then ultimately, we are going to see the negotiation process run into next year. The maximum fair price, which is essentially the negotiated price, will be published just under a year from now, and then they go into effect at the beginning of 2026. So you'll see the 2027 deadline is a little less compressed, but it's essentially a 2-year timeline from when the drug selected for negotiation, that list is published, and when the negotiated prices take effect going forward. So I do want to highlight that ultimately the list of drugs that are subject to negotiation will grow as the years go on. And so as long as drugs meet the criteria for negotiation, they will stay on the negotiation eligible list. They are being selected from the 50 drugs with the highest total Medicare Part D spending, or the 50 drugs with the highest Medicare Part B spending. And you'll see, as I had mentioned, the Part B drugs don't come into effect. Those are the physician-administered drugs until 2028. But they will then come on board, and they will grow just as the Part D drugs are growing beginning with this year and going forward. As I mentioned, the maximum fair price, also the negotiated price, will apply until the drug is no longer negotiation eligible, which would be when it has market competition. So I do want to highlight that there are some drugs that are excluded from negotiation. So drugs with an available generic or biosimilar will not fall onto the list. Drugs with less than 7 years or 11 years from their FDA approval or licensure date, depending on whether they're a small molecule drug or a biological product. I will note that sometimes you hear 9 years for small molecule drugs and 13 years for biological products. And that's just because of that 2-year kind of lag from the time that a drug is selected for the negotiation eligible list. And then ultimately that maximum fair price or negotiated price goes into effect. So you can show up as negotiation eligible 7 years after FDA approval for a small molecule drug, but then that negotiated price would ultimately go into effect 9 years after that approval. Small biotech drugs are excluded until 2029. They are defined as drugs which account for 1% or less of Part D or Part B spending and account for 80% or more of the spending under each part of that for that manufacturer. So again, trying, at least for the time being, to kind of limit the inclusion of drugs from manufacturers that account for a small amount of spending and a large amount of the kind of manufacturer's portfolio. Drugs with one orphan designation as their FDA approved indication are excluded as well. And I think that's, again, trying to make sure that drugs, for rare diseases are protected and not subject to any market changes that might result from negotiation, and all plasma-derived products are excluded as well. So this is the list that was published in late August, right before that September 1st deadline, of drugs that are eligible for the first round of negotiation. I will note that these drugs treat, conditions that are chronic and common in the Medicare population. You see diabetes makes this list a lot. Also arthritis, heart disease, heart failure. So this is kind of that first list of 10. These drugs, according to Medicare, accounted for $50.5 billion in total Part D gross covered drug costs, or about 20% of Part D prescription drug costs between January 1st, 2022 and May 31st, 2023. So that's a significant amount of money. And I will highlight that according to CMS, beneficiaries did pay $3.4 billion out of pocket for these drugs in 2022. So these are kind of that first tranche of drugs, the first ones being subject to the new negotiation program that is really just at its earliest it's in the early part of its implementation. So I did mention that there will be opportunities for public comment. Each drug will have its own patient-focused listening session. Those will begin at the end of this month. Registration to speak actually was originally scheduled to close last week, but they decided to extend that registration until October 15th. And all sessions are open to the public and will be live streamed. There was also an opportunity to submit information about the selected drugs and their therapeutic alternatives in writing. That information was due to CMS last week. I will just focus a little bit on these listening sessions. CMS is asking for patients, beneficiaries, caregivers, and consumer and patient organizations, as well as other interested parties, to share their input on the drugs that were selected in this first round of negotiation. They, again, just like the written submissions in the listening sessions, are really interested in information related to therapeutic alternatives of the drug selected, how these drugs address unmet need, as well as how the selected drugs impact specific populations. And most things with CMS, they are going to be in listen only mode and will not be responding to feedback during these sessions. But this will be the first time that there will be sessions of these nature, since this is the first round of negotiation. So I mentioned that the maximum fair price will be the ultimately the negotiated price. And so the statute does require the following factors to be considered when negotiating a maximum fair price. The research and development costs, including the extent to which the manufacturer was able to recoup these costs on the drug, the current unit costs of production and distribution, the federal financial support for therapeutic discovery and development of that drug. So if there are federal programs like the NIH that supported the drug development, they will keep that, that will factor in as well. Data on pending and approved patent applications, exclusivities, and certain other applications and approvals, the market data and revenue and sales volume data in the United States, and evidence about alternative treatments. And I will just go back actually a couple of slides. Just again, if you can see here, you can see kind of the costs and the beneficiaries. So that's all data that will be kept in mind as they are doing reviewing and setting this maximum fair price. I will note that CMS is prohibited from considering comparative clinical effectiveness research when they set the maximum fair price. So that is something that's not allowed. Moving ahead, so the maximum fair price is going to be the average manufacturer price, the lower of the AMP for a Part D drug, or the average sales price, the ASP for a Part B drug, or the percentage of the non-federal AMP based on the amount of time since it was approved by the FDA. And that's going to be, the ceiling is the lower of either of those amounts. Ultimately, HHS is going to publish information on that maximum fair price and the factors that were used to determine this price. So the factors that I showed you on the last slide, what the agency thought about them when setting the maximum fair price, will ultimately be published. And each year that the drugs stay on the list, if they're not subject to renegotiation, they will ultimately increase by CPI-U. I do want to note that if manufacturers choose not to comply with the negotiation, I will highlight that ultimately all of the manufacturers did choose to participate in this first round, that there were significant financial penalties. And so I do want to highlight that for manufacturers, it might not really have seemed like much of a choice about whether or not to participate, because these penalties are significant, up to 10 times the change in price for each unit charged, $1 million per day penalty for failure to provide the required information, or an excise tax of up to 95% of sales. So, ultimately, these are steep financial penalties. And also looking at this, the government has ultimately set the ceiling and the floor for the maximum fair price. So perhaps it doesn't, isn't a true negotiation, despite the fact that that is what the government has called it. But we are going to ultimately see what happens as this first kind of round of negotiation continues. I will note kind of the fact that the government's setting the ceiling and the floor for the maximum fair price. This was really done to allow for scoring when the legislation was being developed, so there would be a true sense of cost savings. I will add, though, despite what is happening with the maximum fair price and the penalties that manufacturers would have faced for not participating, drugs that are ultimately have a negotiated maximum fair price have to be covered by Part D plans. So ultimately, that is a piece here to consider. The last thing I just want to talk about, and I'm sure you've heard about this in the kind of just in the news, that the IRA is subject to ongoing litigation. Manufacturers have filed numerous lawsuits about the constitutionality of the legislation, and I will note that these lawsuits were filed in different areas of the country, so they would come through different judicial circuits, I think with an eye towards getting potentially a split in the circuit and finding its way to the Supreme Court. I will note that the first date that was of importance, again, I mentioned that that October 1st was the date to determine if a manufacturer was going to participate. And ultimately, that date, right before that date, we got our first kind of judicial decision that they were not going to hold up or prohibit the negotiation as the lawsuits make their way through the courts. So again, as I mentioned, all of the manufacturers have decided to participate in the negotiation process and the litigation will play out, concurrently. So that concludes my prepared remarks, and I know we will open it up for questions.
Yes, thank you, Erica. I really appreciate that overview. There was a lot there. Some of the questions, and I just want to take this minute to remind people, if you have questions, please put them in the Q&A box. It's sort of hard to kind of go between screens, so I'm going to try to do my best. One question that came in, Erica, was what would happen if industry strategy is to negotiate with CMS? What would happen to federal and state supplemental rebates if the government already negotiated the best price? If a large company no longer has to pay federal rebates, Medicaid at 23.1%, and state supplemental rebates, would they negotiate a 15 to 20% federal best price and save hundreds of millions in rebates and administration costs? Wouldn't there be potential for state Medicaids to go bankrupt without those rebates to fund their pharmacy budgets? It's pretty intense. I don't know that there's a lot of questions out there, but just wanted to pose that question that came in.
Yeah, that's a lot to chew on, and I think at this point it's really too early to know what's going to happen. I will just highlight, I know that the Medicaid program was mentioned in that question. The Medicaid program is already subject to rebates. The rebates are only new in Medicare Parts D and B. So nothing is changing on the rebate side as it relates to Medicaid. Will prices change on the Medicaid side? That's, I think, something that has yet to be determined. But I think these are great questions, and to the extent that those with these questions want to engage with CMS, either through the listening sessions, and again, there's still a few more days to register for those listening sessions for each individual drug, or engage, separately. These are good things for HHS to consider going forward.
Yes, I'll second that. Is as many questions that you can get before HHS during this implementation process, the better, just the things that they can consider and look out for moving forward. One question that came in is if you could explain how is the fair price determined?
So I think that is a great question, and I just think that it's something that another question that we just don't know the answer to at this point. I can go back a couple of slides just to show you again what are the different factors that Congress is instructing that CMS and HHS consider. And I will just say, how ultimately manufacturers have to submit information to CMS on these factors. They will have to, review that and, go back and forth between the manufacturers. We know, again, because the kind of the floor and the ceiling was set for the scoring purposes in the legislation, there's not going to be, I think, that much surprise, but ultimately we'll see when CMS puts out kind of what the prices are and the justifications. We'll have a better idea. But again, this is the kind of first time through, and we're all going to be learning together what it looks like when these factors are considered.
Erica, the next question that came in, which I also agree with you. I went into poli-sci in government relations, so I wouldn't have to do math. So the guidance around the Medicare prescription payment plan was a challenge for me. But why is the smoothing process for out-of-pocket costs so complex?
Well, I think that's a great question. And again, I think if we all knew what health conditions we were going to have on January 1st and we were going to know what drugs were going to be prescribed and the costs, it would be really easy to determine whether it made sense to opt in or opt out. But because beneficiaries don't know that at the start of the year, they can opt in at different points. But again, if you know that you're going to have $2,000 in out-of-pocket costs on January 1st, just a $2,000 copay, and you don't have $2,000, it makes sense to opt in and pay that over the cost of the year, smooth that kind of out-of-pocket cost. But if you don't get prescribed, like if you are very healthy and don't have any prescription drugs prescribed to you and maybe are hit with a significant health challenge at the end of the year, that kind of out-of-pocket cost is going to hit you, and you're not going to have much time to pay that out in installments. I think I like maybe like an installment plan better than smoothing.
Okay. A smoothing, yeah,
Yeah.
agreed. Our next question is, why is there a difference in the timeline to negotiate prices for small molecule and biological products?
So biologics are typically seen as kind of more complicated than structures than small molecule drugs, and therefore more time consuming, challenging, and expensive to develop. And so that's why they basically have an additional 2 years before, is it 2 years? No, it's 7 and 11, 4 years, an additional 4 years before they're subject to negotiation. And it's really to account for the costs that are associated with their development because they're seen to be greater. So they have kind of that additional 4 years before they could fall into this negotiation.
Thank you for that. We just can't escape the math, can we? We just can't escape it.
No.
So the question, I think, you sort of touched on it a little bit in your presentation, but how will the drug price negotiation or changing drug costs, how will that impact premiums for Medicare beneficiaries? And if I'll take the moderator's privilege and add on to that, when will we know about what the impact on premiums will be?
So I'm going to answer the later part. I think we're going to have to go through this first negotiation cycle and see what happens with prices in that 2026 kind of initial year before we see significant changes in prices. But I will just, Leslie, I'm sorry. I feel like what's going to happen to premiums? That's the question. Sorry. So I will just say that I think at this point, it's hard to know. Will we see kind of premiums increase? Will we see higher, launch prices, knowing that negotiation is going to come, and will those have to be offset for the time that the drugs are, in Medicare and approved and not subject to negotiation? I think there's a lot of factors that we don't know right now. And whether this is going to affect premiums going forward to try and, recoup some of those costs in other ways.
I think it's just the challenge of when you're implementing a brand new law.
Yeah.
You're going to have to kind of go through it to figure out where the impacts are really going to be.
At this point, there could be a lot more questions than answers when it comes to this law. We can tell you what's in the statute and what we think the impact on beneficiaries is, and what we think what we know some of the criticisms of the policy are. But what actually plays out, we're gonna have to wait for all of these different pieces to be implemented.
No, I think that's exactly right. And the next question is, and I think you touched on this a little bit too, but how will patients know if the Medicare prescription payment plan will benefit them? Because it's not going to benefit everybody.
Correct. And so I think it's going to be really important for those who are interested in this to keep an eye out for the second guidance. That is really going to allow the public to comment on how outreach should be done to beneficiaries. I've heard it suggested that pharmacists should be counseling beneficiaries about this. I'll just say, I live in DC. I don't want my CVS pharmacists to counsel me on anything. I can barely get them to dispense a prescription, but should pharmacists be the trusted source? Should physicians, who, have an idea of what they're prescribing to patients, and then if they have information as patients are making decisions about enrollment, that they can counsel them? Should the actual plans themselves have information just based on your historical spend, and can make that recommendation? Obviously, every beneficiary is in their own unique financial situation. So even if the CMS calculator says it makes sense, maybe the beneficiary doesn't feel like it makes sense for them. So it will ultimately be a decision that everyone will have to make individually, but it's really important that CMS empowers beneficiaries to have this information. And again, I think this is what's going to be sorted out in the next guidance. The original guidance kind of asked some preliminary questions about these issues, and I think we'll get into this in more detail in the next guidance.
No, I think that's right. I think there's, those in the patient community had really talked about having the beneficiary have the choice whether to enroll and when to disenroll, and having that be very easily done. Because like you said, finances change, circumstances change throughout the year. Related to that question, so what will be the impact of drug price negotiation on patients? And when can we expect to see the impact on the communities that we represent?
So I will highlight that in terms of ABC, the brain health community, we did not see those first 10 drugs impact neurological and brain health conditions. And so, it's going to be a while for this community. We'll have to look at the kind of drugs that are selected for the 2027 negotiated price implementation before we might see something that affects brain health. But I will say that this is going to affect all Medicare beneficiaries differently. Ultimately, it's going to depend on whether the drug that you are prescribed is on that negotiated list. And if it's not, then you're not going to see kind of the cost of the drug go down, and then your kind of copay requirements go down accordingly. Because if you have a 20% copay, if the kind of price of the drug goes down, then your 20% responsibility will go down as well. So it's going to depend on what drugs you take and if they are on that list.
Sort of related to that question too is, how do you expect the Medicare price negotiation, so the maximum fair price, to impact the cost of drugs outside of Medicare? Or is that something that will happen?
Yeah, Leslie, I think that's a great question. This only applies to the Medicare program. So, the prices for those of us who are in private insurance, there's no reason that they will necessarily change. There is the factor, if you know that the Medicare is paying, $100 for a drug, and in the kind of private plans, you're paying $500 for a drug. Is there some sort of public shaming that will drive the cost down in the private markets? That could happen. Could prices go up in the private markets? Again, that could happen too. It's, I think, one of those things that we're going to have to say, wait and see. But there's no requirement in the law that the prices for those who are privately insured be changed at all. This is a Medicare Part B and D program only.
Good to keep in mind, and another thing that we'll have to kind of wait and see what the response will be in the markets. So another question came in the chat: will the IRA impact pharmaceutical research and development? And if so, how?
So I think that's a great question, and one that has been subject to a lot of speculation. When this was originally scored by CBO, it was found that there would be a minimal impact on research and development, less investment. I think ultimately, I'm not in a position to answer that question, that ultimately the manufacturers will, be able to say after a certain amount of time and having drugs subject to this, negotiation for them, for us to see it. But again, it's another wait and see. And I know that that's a concern, and it's a big concern in the brain health community as we're looking for. So, we have a need for new therapeutics.
No, I think that's right, Erica. And I know that we've had many conversations about that on the advocacy committee. I know that on the line, we have a couple of representatives from the ABC board where we've also talked a little bit about this, just, in terms of the needs for the neuroscience and brain health space. So I wonder, and this is where technology may help us here. I think Michelle Oshman, who is a fellow ABC board member, is online. Can we unmute Michelle? Maybe you could offer some perspective here.
Sure. Can you hear me all right?
We can.
Excellent. All right. Well, thanks so much for the question, and definitely appreciate how you have laid out the conversation today. It's certainly, so I'm Michelle Oshman. I am part of the ABC board. And for those that I might not know, I also lead external affairs for BIO, the Biotechnology Innovation Organization, and we're a trade association representing biotech. And I will say that certainly our member companies are extremely concerned that the IRA provisions across the board certainly will have a negative impact on innovation. I think the argument is it's certainly not a simple argument. What we're seeing now, if you think about the early stage companies, so Bio represents 1,000 companies. Some of them are one-person companies that are just spinning off of a university. Some are, enormous multinational companies. For those early stage companies, we are really starting to see the impact that on investment. So their investors, if they're in their Series A, Series B, raising funding rounds, are actually, those investors are saying, you know what, biotech seems like a big bet right now, and this IRA thing isn't good. So we're gonna invest in tech instead, or whatever other sector. The investors don't have that allegiance to the healthcare space necessarily in the same way that all of us do. So we're seeing that, and that certainly will impact R&D, because a lot of the gene therapies and really sort of new and innovative technologies are coming out of that community. But certainly also we're hearing from our member companies that are larger, that are the big multinational companies, really making decisions about their pipeline. Their risk tolerance is lower. And so their decisions as to whether or not to fund a given portfolio or molecule for research is being affected by the anticipated hits that those companies would be facing from the IRA. So I think when you hear somebody from the industry like myself say this is definitely going to impact R&D, it's a little wonky and a little technical as to how it will affect those investments. It's multi-layered, but based on the financial analyses that we've done, and certainly that our member companies have asked us to do, we're already starting to see those effects. And once IRA passed, there were a couple of companies that were pretty public about the reasons that they shut down a given pipeline. So it's a confluence of factors, but we certainly anticipate there'll be challenges there. On the flip side, as I know you all have talked about, the cap on for Part D, the out-of-pocket cap, that again is something that all of us as certainly at Bio have long supported. And so the trade-off isn't, I wouldn't say at least from a Bio perspective that it's a fair trade-off, but we are happy to know that the out-of-pocket piece is addressed and will be in 3 years' time. But the R&D impact is very real, and I'm happy to chat offline if anyone has questions about that.
Thank you so much, Michelle. I really appreciate it. I know everyone appreciates your perspective on here too. And I appreciate you being willing to be called on when, it wasn't exactly in the plans today. So I appreciate you.
I'm glad I was paying attention.
Yes, yes. So I think we'll have time for one more question. Erica, do you expect that Part A hospital and physician fees will also be subject to negotiation down the road?
So that's a great question. I do want to highlight that Part B drugs are physician administered, And so some of those drugs are falling into negotiation now. I will say that those drugs are currently paid at ASP +6. And what is specified is that they will be paid at 106% of that maximum fair price. So that 6% administration will still be there. But again, if the maximum fair price is lower than ASP currently is, then that is a cut to physicians for administration. I don't think that physician fees and DRGs in Part A are going to be subject to negotiation. I'm not going to bore everybody with the details of how these rates are set. I will say for Part A DRGs, there is a complex cost reporting structure that ultimately goes into effect, and that's based on actual data that's reported from hospitals to CMS. In physician fees are set through another kind of arcane and complex process and consultation with physicians already. So I don't think that this is something that is going to fall into, hospital and physician rates anytime soon.
Well, thank you for that. And I don't see any more questions in the queue. I will go ahead and kind of bring us to a close here, but just to say, if you do have questions, please feel free to reach out to Katie or I. We're happy to sort of filter those questions through to Erica or others who may be able to address them. But thank you, Erica, for all of your conversation around this today and for your overview. I know, there was so much that we talked about in terms of where the IRA is and the policy impacts on this, on the brain health community. So really appreciate your expertise in navigating this very, very complex topic. So thank you so much. Also, thank you to Katie Sale and Sheila Stern from ABC for providing so much help with technology. That is not my strong suit. So thank you so much for all of your efforts. And as a reminder, this webinar will be recorded and up on ABC's website within a few weeks. If you want to share this with your colleagues or share this with others, please feel free. Again, thank you so much. And if you have ideas for other educational programming, please reach out to Katie. These are things that we love to be able to respond to from ABC members, and really appreciate you reaching out to us with ideas. So thank you so much. Enjoy the rest of your day, and we'll see you soon.